Welcome to the other side of Lucy Letby. In episode 36, we're going to look at the cases of babies L and M. Letby was found guilty of attempted murder of both of these babies. One by insulin poison, that's baby L, and the second, baby M, they were twins. By our old standby or embolism, without the slightest shred of proof of either. And one of the very few things that I found out when I read Judith Morris' book was in this case, the amount of error was 0.4 mil, 0.4 mil of error put into a port device that's a little three-way tap that you can open up into a central line or a line into a baby. And this 0.4 mil of error acted as a kind of time bomb. It got sucked in gradually and built up in the baby's blood so that provided the excuse that Letby was nowhere near the baby when the collapse took place and actually responded to the collapse, which is called a sudden unexplained postnatal collapse, which we talked about in one of the podcasts with another nurse, not on her own. There's no doubt that this is a rare occurrence, but there are reasons why it can happen. And remember, we are dealing with a preterm neonate who is very low birth weight, and whose mother was in hospital for a prolonged period of time before this incident happened. So we looked at that a bit later, but we'll get on with the case of baby L first. Now, in terms of science, physiology, biochemistry, etc., I think these cases are right up there with the highest farce that you can get. They are pure inventions. There's not a slightest bit of evidence that Lucy Letby did any harm to these babies at all. And the expert witnesses have to go to extraordinary lengths to concoct the tale that Lucy Letby harmed these children, because no one witness remembered that Lucy Letby harming anyone. So the basic facts of the matter: the twins were born on the 8th of April. BBL was one of the two so-called insulin cases, the second of them, which they claim is proven beyond reasonable doubt on the basis of a single immunoassay test for insulin and C-peptide. So I'll explain what an immunoassay test is in a minute. But before that, we're going to look at a case study. This is a description in a journal of an actual poisoning by exogenous insulin. And I think we should have a look and see how this differs, or does it differ in any way from what we see in the case of BBL, and was the symptomatology and the clinical findings similar to what we see in the case of BBL and indeed BBF, the other supposed insulin poisoning. So in this case report, for context, we have a preterm neonate twins, same as BBL and M, and their gestation in this case was 33 weeks. So it's in and around what BBL and M would be. And the birth weight was 1.5 and 1.4, which is, again, around what the case is for BBL. And the mother had a normal delivery, but the babies both had, of course, respiratory distress syndrome, and they were in the ICU for 2 weeks and then discharged, no problems. The parents presented the children to accident and emergency 30 days later, and the father said that he had witnessed the mother, who was suffering from postnatal psychosis at this time. He had witnessed her injecting with Act Rapid both babies with insulin. Now, the first baby was fairly stable, and it received IV boluses of dextrose and an IV dextrose infusion with a glucose infusion rate of 6 milligrams per kilogram per minute. So that's pretty standard. The hospital asked the family to bring in the other twin, but they didn't bring it in until the following day when the baby was very ill, and both of the twins developed hypoglycemic seizures and had to get glucagon, which is the kind of opposite hormone to insulin. They had to get boluses of that and an infusion of that to reverse the effects of the insulin they'd been given. And even that wasn't enough. Several infusions had to be given to the babies over the next 3 or 4 days. And the second twin was actually so ill, it was put on a ventilator and to stay in the hospital for 2 weeks. So, and the amount of steroids and glucagon and diazoxide and different drugs that the doctors needed to reverse the effects of this insulin was pretty impressive. And the reading for the immunoassay for insulin in the baby was around about 1,500 picomoles per litre. So in baby L, we know that it was 1,000 picomoles per litre, a little over, and for baby F, 4,600. So it is more than reasonable to expect that both baby F and baby I would have had serious clinical consequences of that level of insulin in their bodies, but that they didn't, neither of them. In the cases of the twins here in this case study that I'll link for you, the C-peptide was unmeasurable. They couldn't measure it at all. And in the case of baby L, the C-peptide was in a perfectly acceptable range if we go by picomoles per litre, which is a measurement that these experts seem to be using, picomoles per litre. So for both cases, we're definitely in the ballpark. But for baby F, we have 3 times more insulin in the baby with no symptoms. And in baby L, we have slightly less insulin, but not much less insulin in the baby with no symptoms, and a lot of C-peptide. So it doesn't really add up. And the whole thing doesn't add up to me clinically anyway. I've seen over the years a good few accidental excessive insulin administrations, but they were always accompanied by quite profound symptoms. And the patients had to be hospitalized and stabilized, which took days in all the cases that I encountered. Now, as I say, the mother of these children in India, she had psychosis after pregnancy, which is something that can happen. And the husband witnessed her giving the insulin to the babies, and that's how they were so quick on the ball with this thing. But I do think that the 2 cases are well worth comparison. It's a single case, and it's not normally what you would do in medicine. It's just a lesson, a demonstration. But don't forget, these experts used one description of skin discoloration in a paper, the Tanswell paper in 1989. They used that single observation of that to pin every discoloration onto Letby and accuse her of injecting her into babies. But you just simply can't do that and be an honest broker. It's not how you would practice medicine. And if you did, you wouldn't get very far. Getting back to baby L. Baby L was born on the 8th of April. Now, the mother had some kind of complication in the pregnancy, and she was hospitalized for 2 weeks. We don't know what that complication was. We don't know what medications or anything were given to the mother, and that should have been gone into in great detail, but it wasn't. And they were twin boys, and they were born on April the 8th, and baby L was admitted to the neonatal unit at 10:30, and observations were, of course, taken by Lucy Letby. with a blood sugar reading of 1.9. Now, that was probably a blood gas reading or a bedside reading and not a laboratory reading because it's recorded at the time of admission. So for all these readings that we're going to do now quickly, we have to remember what Professor Hindmarsh, the expert in endocrinology, said during the case of BBF about these measurements. First of all, he said that 2.6 was a normal reading, accepted as a normal reading. He also said that 0.8, the difference between a bedside test and a laboratory test, was acceptable. So we can add 0.8 to any one of these readings that we have to get an acceptable reading according to Professor Hindmarsh. With regards to that, it depends very much which study that you look at. So, of course, there's individual variability. So one study I'll quote found that the blood glucose levels varied from 2 to 15% measured by the two different methods, the bedside method and the laboratory method. And the accuracy was low for point of care, that's bedside one, when the glucose was low. And the differences were ranged anything from 0.55 to 1.11 millimoles per liter. And the normal glycemic, so that's the ones with the normal, the point of care measurements seem to be okay when the blood sugar is normal. And there are systems that are very accurate and correlate well with the laboratory tests, but none of them correlate well with the laboratory tests when the blood glucose is low. Therefore, you cannot use point of care glucose measurements to manage these babies, and you certainly should not be able to use point of care data as forensic evidence in a murder trial. This is another problem with this trial. I have seen people do heel prick point of care blood glucose tests and mistakenly somebody else does one 2 or 3 minutes later, and they're completely different. So they're useful as a screening tool, but they are not useful as a clinical tool for managing the problem, and definitely not suitable as a forensic tool. So that should have been challenged really in the court as well. And there's a couple of other things that we have to note in here. First, there's constant reference to hypoglycemia persisting in BBL, even though the readings are above 2, and we know that there is that margin of error according to Professor Hindmarsh of 0.8. So at no point did these blood sugars crash to a very, very low level, like under 1, that you can sometimes see practically not measurable. Secondly, the initial prescription written up for BBL dextrose was scored out twice, and a third prescription written. Judge Goss asked for clarification on that, and the clarification was the glucose infusion rate. So whoever wrote up the first 2 bags hadn't put in an adequate infusion rate, and that had to be altered. I don't know who altered it, but putting an infusion rate or deciding on an infusion rate for a neonate is calculated on its weight, and it's usually between 4 and 8 milligrams per kilogram per minute. It's standard, and it can easily be adjusted by measuring the blood glucose as the infusion is running. So I find it odd that the initial infusion rate had to be corrected twice for such a simple and common problem like hypoglycemia in a preterm neonate. C-peptide reading was less than 169, meant that it was not accurately detectable by the system. So she admits in evidence in court for a murder trial again, when we're talking about evidence that should be of a forensic standard, that the machine couldn't accurately measure the C-peptide. Dr. Yuko, registrar in the case of BBL, also said that he did an incomplete hyposcreen. So when these babies have hypoglycemia, you have to do a whole range of blood measurements of different amino acids, fatty acids, ketones, electrolytes, all kinds of things. There's a huge, big panel of tests, but they weren't all carried out in the case of BBL, according to Dr. Uko. So this means that, again, we don't have a forensic standard to put into evidence in court for a murder trial. So we just go back to BBL and look at this timeline and the symptoms that BBL demonstrated with such a massive amount of insulin, apparently, in the blood. On the 8th of April, as the day of the birth, 11 a.m., 1 hour later, we get a 1.9 reading. And the baby was started on 10% dextrose infusion. And Lucy Letby notes, written in retrospect at 5:42, noted the blood sugar reading was 1.9, with the registrar ordering dextrose infusion and to start breastfeeding. So, typical hypoglycemia in a preterm neonate. Nothing to worry about. Start the dextrose, start the feeding, let's see what happens. At 4 o'clock, the blood sugar reading is 5.5. So we can say that that blood reading is accurate because it's in the normal range. So these tests, as we say, are probably accurate or correlate well with laboratory tests in the normal range, but not in the low range. At 6 p.m., the reading was 3.3. At 9 p.m., 2.3. 10 p.m., 2.2, and then 3.6 at midnight. No worries here at all. Further medication was administered during the night, but we don't know what the medication was and why they used it. Again, something that should have been questioned in the evidence. And then during the night, we get the high specialty of the County Chester Hospital that the line feeding the dextrose into the baby was knocked out, but we don't know for how long. All we can say is that for a period of time, overnight between the 8th and the 9th, BBL didn't receive dextrose. Again, not questioned as to the duration and how much dextrose it missed while the line was resighted. 10 a.m. then on the 9th, the pre-feed blood sugar is measured at 1.9. Now that's going to be a point of care reading and it's not going to be accurate. But the dextrose infusion was increased anyway, according to Nurse Griffiths, who was a designated nurse for BBL. We don't know what the initial glucose infusion rate was. We do know that it stopped in the middle of the night, blood sugar fell, and now it's been increased as a consequence of that. 11 a.m., blood sugar 1.6, and the results of the hyposcreen or partial hyposcreen are entered into the record with no signature on them, and we don't know what the results of the partial hyposcreen were. That's not in the evidence in the public record anyway. 2 p.m., blood sugar reading 2 and 1.5 at 3 p.m. Again, we don't know if these are point of care tests or laboratory tests, but they're likely point of care tests, and they're possibly not accurate enough to guide clinical decisions, and certainly not accurate enough for forensic analysis. At 3:35, the blood sample for the C-peptide and insulin immunoassay is taken from the baby with a note saying that because of an emergency, the sample was not thawed at once, but was taken to the lab. Again, not good enough for forensic use. So we have a pretty sketchy chain of custody here for a sample that's about to be used as the sole scientific evidence with which to condemn someone to a whole life term for murder. It just isn't good enough. And I doubt that it would be accepted in any other civilized jurisdiction. But continuing on, 4 p.m., 1.5. So the dextrose is changed from 10% to 12.5%, and we get a 1.5 reading at 5 p.m. and a 1.9 reading at 6 p.m. p.m. 2, 9 p.m. 2.4, 10 p.m. 2.3, midnight 2.1. This is on the 10th, and the long line is inserted. We don't know how long it took to insert that line, and we don't know if there was any dextrose running at all during the period of putting the central line in. So again, there could have been a gap where the baby didn't get any dextrose at all. I'm just not sure about that. And more medication given, but we don't know what that medication was. And again, the decision to use a 12.5% solution into a peripheral line is a controversial one. Some hospitals would advise against doing it. 4 a.m., 2.3, 6 a.m., 2.2, 7 a.m., 2.2. Remarkably stable for a baby that is supposed to have such a massive amount of insulin being away into the feedback. No mention yet by anyone of any seizures or problems with the heart or need for intubation, as we described in the known case of exogenous insulin administration in the case study in India. 2 p.m., blood sugar level is 3. BBL is switched to 15% dextrose Sunday afternoon, and all the bloods begin to stabilize after that, and there are no more low readings. Letby complains about the very poor skill mix on the unit and how crazy and chaotic it is. So we've heard this so many times before, not just from Letby, but in the case of BBL, BBL suffered no consequences noticeable apart from irritation, which could happen for any reason anyway, particularly if you're putting hyperosmotic solutions, which are likely to be painful because they're often associated with a breakdown of veins because they're just too concentrated for a peripheral line in a very small baby's vein. Into peripheral lines, and you're inserting long lines, all of those things are going to stress the baby out. But there were no seizures, no cardiac problems, no need for intubation, nothing. The baby's temporary hypoglycemia disappeared and the baby came back to normal. So what's the big deal? You have to ask yourself. How common is this in preterm neonates, particularly babies around 1,500 grams? Well, it's extremely common. And we know that all of these tests, or most of these tests, were the bedside tests, which are not accurate. And we likely know that because one test showed that the sodium in the baby's blood was beginning to fall. And that is because they were using hypertonic solutions. So hypertonic solution is basically just a more concentrated solution than the plasma of the blood would normally be. And it means that when you put it into the plasma, the additional osmotic pressure, that's the pressure that's going to pull water about. The increase in that is going to pull water about in from cells, out of cells, and that's going to mess with the sodium. So it also shows that there wasn't proper management of the electrolytes during this whole procedure as well. These doctors clearly weren't particularly worried about BBL. It was responding as it should do to the adequate doses of dextrose. These are very common problems in preterm neonates, and many of the studies each give different readings. One major study found it was present in 31% in the first 24 hours of life, and another source quotes 30 to 60% in high-risk infants. That would be the preterm neonates. And the severity, very variable as well. And typically, it's not regarded as persistent hypoglycemia if it resolves within 3 or 4 days. So a very high possibility that BBL would have had hypoglycemia in the normal course of events for preterm neonates in intensive care. There isn't a typical value of glucose infusion rate or the amount of dextrose that you would have to give to correct hypoglycemia. And so it's typical to escalate the amount of dextrose infused over a period of 24 hours from 8 to 10, 12, 15, and even more milligrams per kilogram per minute until you achieve a steady state of glucose in the baby. BBL was entirely asymptomatic for severe hypoglycemia, and most of the tests used were bedside tests, which are not accurate at those levels. So the only forensic evidence we have is this insulin C-peptide ratio immunoassay test carried out at a hospital in Liverpool. So what is an immunoassay test, and does it actually measure insulin or C-peptide? Well, if we compare the two methods that are normally used to measure insulin and C-peptide and all of these hormones that are present in the body in very, very tiny quantities, immunoassays use antibodies that specifically bind to the target molecule. So you have an antibody that is designed to attach to the insulin. So the test itself is only as accurate as the binding of the antibody. And the problem with immunoassay tests is that they are not always specific enough only to pick up the antibodies that you want them to pick up. There are many other antibodies that they can pick up and fool the test into thinking that they're actually measuring insulin when they're not. They're measuring an antibody to something entirely different. The most accurate way and the forensic way to measure insulin and C-peptide is the use of liquid chromatography, tandem mass spectrometry, LC-MS-MS. And this is designed specifically for this purpose. And it has an enhanced precision, much better precision, for instance, and selectivity compared to immunoassays. But its advantage is that it can directly detect and quantify insulin without relying on antibodies. So you don't get this problem of the immunoassay test interacting with substances that are not insulin. And that allows for specific quantification of insulin and not its analogs or these other interfering substances. And the other advantage it has, it can simultaneously measure insulin and C-peptide. So there's no delay in testing one and then testing another. So mass spectrometry-based strategies are much more specific towards insulin and its major degradation products. So you don't have this controversy at all about what is the immunoassay test interacting with. And they can differentiate. These machines can differentiate between endogenous insulin and exogenous insulin. But the immunoassay test cannot reliably 100% of the time distinguish between endogenous and exogenous insulin. The liquid chromatography can also measure down to very, very low levels, which the immunoassay test can't. So it has so many advantages. It can quantify multiple peptides from the same protein in a single run. It can detect variants of the proteins and post-translational modifications to the proteins. And the other thing is that they can be standardized across all laboratories. So this would be the forensic standard that you would need to stick someone in jail for life for poisoning someone with insulin when the only evidence you have for that is a theory. You have no proof, you have a theory. As I've said before, no one checked the bags for insulin, so nobody knows that there was insulin in the bag. And the immunoassay test is not accurate enough for the purpose of jailing someone for the rest of their lives. There is more than reasonable doubt that these tests are not or were not accurate. But the tests themselves, as they're reported, don't seem to make a lot of sense, at least to me. We have massive amounts of insulin present in both these samples. But we also have quite normal amounts of C-peptide. That may be possible because we know that exogenous insulin, so that's the insulin that was supposedly added to the bag, we know that this insulin doesn't always suppress the release of natural insulin in these little preterm babies. So you can get insulin release and exogenous release happening at the same time. And that would explain the presence of C-peptide. Now, this is particularly important in the very preterm neonates. We've seen in the example, the single case example that I gave you earlier, they couldn't measure any C-peptide at all. Yet in these tests, we're measuring C-peptide levels that are within the normal expected range. And this is typically what you would find in the very preterm babies, but which resolves itself by the time they're 30 days old, as in the case of the babies from India. The very preterm neonates can have this coexistence of exogenous insulin plus endogenous insulin, but that wears off with post-gestational age. Some neonates have very low C-peptide levels, that's 2.5 to 9 picomoles per litre, and others have comparatively high levels, 9 to 526. That's such an enormous variation. And one study quoted the C-peptide plasma concentration in hyperglycemic neonates, this is neonates with high blood glucose levels, increased with increasing gestational age. And C-peptide concentrations were significantly lower in hyperglycemic preterm neonates compared to normal. There are so many factors involved here that are not discussed in this trial. It's not just the production of insulin, it's also how fast the baby can get rid of insulin and how fast they can get rid of C-peptide, which is called the clearance of C-peptide. Let's get back to a simple analogy for insulin C-peptide. So imagine you have a distress flare and the flare has a cord attached to it. The flare won't go off until you pull the cord. When you pull the cord, the flare goes off and you're left with a used up flare and the cord. So the cord is the C-peptide and the flare is the insulin, which has now been used up. Unless you pull the cord, the insulin won't work as well, if at all. And when you do, you have one of each. And that is said to be equimolar or equal amount. Now, because it's claimed that the half-life or the rate at which you get rid of insulin is known, and the rate at which you get rid of C-peptide is known, you can calculate what should be the expected ratio between the two in a normal state. But that makes a lot of assumptions, particularly when you're using immunoassay tests. And the problem with the immunoassay tests is that they don't just interact with insulin. And this is particularly important in preterm neonates. So insulin and C-peptide, as the name suggests, are peptides. And a peptide is simply a chain of amino acids that's less than 50 in length. And these are programmed by our DNA. Now, even though each peptide would have a different sequence of the amino acids, a lot of the sequence lengths within that 50 peptide chain overlap and are similar to other peptides that are not either insulin or C-peptide. The precursor of insulin C-peptide is another protein called proinsulin. So a lot of the amino acid sequences in the proinsulin are going to be present, obviously, in the C-peptide and the insulin. And proinsulin can appear in significant quantities in the blood of these little babies. So they can react with the amino acids. Proteins called insulin-like growth factor 1 and 2 are very important in preterm neonates, and they are very similar in structure in some parts of their chain to insulin, and therefore they can interact with the amino acid test. And these are really important in preterm neonates. There are binding proteins, so these are proteins that are used to transport these hormones from one place to another. And there's one called insulin-like growth factor binding protein. I know that's a very long word, but that's what it does. And it can indirectly affect insulin measurement by immunoassay. In other words, without getting bogged down in boring science, there are many reasons why an immunoassay test, particularly a single immunoassay test, is an unfair test to use to prove that someone has circumstantially poisoned a baby with insulin. We have a superior technology that would tell us exactly what the composition of these peptides were in the blood, and that superior technology wasn't used in the case of Lucy Letby. So in the next episode, we'll get on to the evidence of the experts and what they said about these test results. But the important thing here, the clinical picture of these babies was not suggestive at all of the huge levels of insulin found in BBF and in BBL. And that wasn't argued sufficiently in court. In the case of BBF, Professor Hinmarsh, for instance, said that vomiting was a sign of hypoglycemia. Well, look at vomiting. Vomiting is a sign of practically everything in preterm neonates. But if we look at vomiting compared to the case we mentioned earlier, where the twins, one of the twins had to be ventilated because of high levels of insulin in the body, there's a huge gap between this symptomatology of vomiting as a cause of hypoglycemia. It's a way down the list of symptoms of hypoglycemia, of severe hypoglycemia. And we see in BBI that the blood glucose is too consistent. It's just simply too consistent. We have a break in the infusion, which would mean a break in the steady state of the proposed insulin poisoning and in the delivery of dextrose. We don't know how long that was. So it doesn't seem to me feasible that anyone can calculate the proposed dosages that let be added to bags, to multiple bags. It's just too fantastical. We don't have enough data points to draw that conclusion. So it's an opinion. It's only an opinion to which there are very reasonable counter arguments. An opinion should not be sufficient to put someone in jail for life. And we see the same old Problem again with this ward. The blood result is written into the file. No one takes any action on it. There's no consultant input at all. Until years later, when someone happens to do a retrospective analysis of these cases, picks up an anomaly and assigns the anomaly to Lucy Letby. It's just a clear pattern that happens all the time in these cases, and it's appalling. Normally, people wouldn't do these tests until the baby was like 5 days, 6 days into a very stubborn, unresponsive hypoglycemia, but that wasn't the case here. So this is, in my opinion, a trumped-up charge just to add to the list of things that Lucy Letby did for which there's absolutely no evidence. And it was stated in court that this was the only possible interpretation of this test, which is scientifically not correct. There are babies that have what are called transitional hyperinsulinism. They have high, very high levels of insulin for short periods of time, during which you could get a pattern similar to this. You couldn't simply rule it out. There's reasonable doubt everywhere. So I certainly don't take these cases seriously. I think they are evidently they were cherry picked out to pin on to Lucy Letby. And we have to remember that the insulin cases were pivotal in convicting Letby because they were amongst the first that the jury found her guilty of. This is just simply not good enough. It's not good enough. So we'll leave it here now, and in the next episode we'll get on to how the expert witnesses explained this sequence of events and see just how ridiculous it is and how much you have to stretch the imagination to reach this conclusion. Just simply by saying to the jury, there are these three possibilities, and not add the fourth possibility that the test was wrong and there was no insulin in the bag, is deceitful, in my opinion. It's not what you would expect from an objective, scientific analysis of what actually happened. So we'll see you in the next episode where we carry on with BBL, and we'll do BBM, which is very straightforward. Again, I don't know how that got into a charge sheet at all. So we'll see you in the next episode.